Welcome. For this session, the focus is on anatomical ablation for persistent AF, case and early experience. We have a case presentation from Nicolas Derval from University Hospital of Bordeaux, France. So welcome to Nicolas and also to our panel for the session, Larry Chinitz from New York and Brett Gidney from Santa Barbara. Now I'll hand it over to Nicolas for his case.
Hi, Devi. Thank you very much. Good morning or good evening to everyone for that case, depending on where you are. So today I want to present you our experience with the anatomical ablation for persistent AF using the dual energy catheter. So I will start briefly by showing, so this is my disclosure. And briefly, before to jump in the case, really, I want to re-explain briefly how we do, what is our strategy for persistent AF. This is something we've developed since 2018. So the main idea is to have a comprehensive ablation strategy. It means that we want to target all the native muscular network that is prone to promote AF, to prime atrial fibrillation and to maintain it. And so there is different steps in that strategy. First, we want to target, of course, the pulmonary vein, which is really the cornerstone of the vein, of the AF. Then we will focus on some anatomical structure that will also have some implication in AF, such as the vein of Marshall. And then we will block the three native main isthmus of the atrial. And so this was our initial strategy using the Marshall plan. So the first step was, of course, to do ethanol infusion, then PV isolation, then the lines. So there was some question at the beginning, should you ablate over the low voltage induced by vein of Marshall? And we've realized over time that this set can be a little bit optimized because we've understood along the way that there was some challenge to produce this set. So first of all, we usually do systematic ablation in the area of low voltage induced by vein of Marshall to ensure that there is absolutely no reconnection. That's something we've seen. We have better understood the CS connection with several papers that we've published. And so we do systematic ablation at the CS. And the last thing that has some implication today for the set that we're doing using PFA is that the roof line is sometimes a problem to block because of the septopulmonary bundle, which has an epicardial curve that is sometimes prevent from being blocked by fat interposition. And the floor line that is a bit below at the inferior pole of the right veins, this floor line is usually more easy to ablate because there is less fat interposition. But of course, because of esophagus presence, this is something we decided with radiofrequency not to target in the first go. But with PFA, it's something that we can now target as a first go because we don't have the risk of the esophageal. And so this will improve and facilitate the set. So let's go into the case today. And using that strategy, of course, we've demonstrated recently that this strategy was better than vein only in a group of patients with persistent AF. So let's jump into the case. It's a very recent case that we did in the lab 2 weeks ago. So it's been really mounted last week. So it's really fresh. It's a 71-year-old male. He has a history of hypertension and transient stroke, mild hypertrophic cardiomyopathy, and he's in AF since 12 months. Let's go into the case. So I guess, yeah. Here we go. So as I told you, the first step will be to do the vein of Marshall. So this one will be briefed as it's not the focus of the case. So we can see with the CT where is placed the vein. And so the first step will be vein infusion. And so it's really a daily, daily case because as a matter of fact, this vein was not so easy to do. as you see, the first injection, we don't really see anything. But then looking more closely along the valve, then we see a little vein that you can see here. So the angle between the entrance of the catheter and the vein itself is a relatively sharp angle. And so it was quite a challenge to put a guide wire in that vein. But so we've managed to do so. And you see, this is the guide wire that enters the vein. We have a Lima catheter, and then you will see a balloon that will be gently introduced at the proximal aspect of the vein. And once the balloon is in place, you can see the two marker of the balloon. Then we can withdraw the guide wire and inject into the vein. So this vein was, as I told you, not so easy to, so there was some manipulation in it and probably a small dissection at the entrance of the vein. But still, the contrast went into the good area of the reach. And so we do sequential injection of ethanol. And this was, you can see the contrast tattooing of the tissue from the vein at the end. So let's go now really to the case itself. So this is the map that we've produced after ethanol infusion. So the patient is in AF, and you can see this is a relatively large atria. We are above 250 milliliter. But it's a nicely volted atria. There's no low voltage. There's only that posterior low voltage that is really consequences of ethanol infusion only. So our experience has been so far, we do a bit of the same like in the smart fire strategy. We do radiofrequency, standard radiofrequency on the anterior part because maybe there is some interest to the neurovegetative impact of radiofrequency. And then we use electroporation for the posterior part. And so we will see at least one lesion live because this is something I want to discuss a little bit. So this, you see, once the catheter is in place, then you can start the PFA and it will launch pulses and you can monitor the pulses along the chute itself. And so we have not followed the current recommendation of PFA application because our first experience, especially for the roof, were a little bit deceptive in terms of lesion formation. And so we have decided to move for a longer application. And so you will see that in most of the case, we go until the 24 max application. And so as you move up, so this was the inferior part, but as you move in that area, you will see that now we are getting in closer relationship to the bronchus itself. And this is something we've seen with that catheter, that you can have some bronchus reaction and some coughing. That can sometimes, you can see that sometimes the catheter is moving a little bit. And this is because of the close relationship with something I did not tell you. This case was done under local anesthesia, not under general anesthesia. And so look at the X-ray. You see when you reach that upper part close to the bronchus, then you will have that movement, relatively sharp movement that is sometimes difficult to handle, really a good lesion at that stage. But also when you reach that upper part, the esophagus usually is a little more distant. And so you can switch to RF and finish that little piece of part relatively safely, I think. Because here in that area, really the coughing was a little too important. Right veins, we do the same. You will see that we create that lesion using radiofrequency, really standard way. Something that you have noticed maybe is we use 2 millimeter size ablation type because we really want to be sure that we have a continuous lesion. Doing the same on the posterior wall with PFA. I think I will have a stop a bit later on to follow another complete application of the system. Voila, here we go. We have a complete, so you can follow one application. You can track down to have an impression of what is the time that is representing. A little bit of movement of the catheter along that time. But otherwise, again, I remind you, it's a local anesthesia patient. And the patient tolerated very well the case. Well, this is a full application of 24 application. This is the max you can do. And then we finish with the upper part of that.
Nicolas,
so this is a complete lesion set for the vein. And now we will switch to, so as I told you, we will switch straight to the floor line. We don't do a roof line anymore because this is not a safety concern now, and we know that it's more efficient. So again, especially for the floor, we have decided after the first cases, the two first cases, that to switch to a more higher application duration was much better. And I will give you some numbers about our success rate. But here, compared to RF, you are really able to deliver the full application that you want to do. And then the mitral. So we start the mitral really at the ridge. So something that is a bit annoying, there is a background noise on the catheter with that system. And so sometimes it's not very easy to appreciate the signal. So here we wanted to have a bit of atria, but a big V to be sure that we are really on the mitral side of the application. And then we will follow the low voltage area that has been generated by ethanol infusion with this close by application. Again, 2 millimeter tagging, very almost overlap ablation. Then systematic CS ablation. So our experience with the CS has been, so this is, as you can see, radio frequency application in the CS, because from our experience, we have seen, first we had one spasm despite nitrate injection. It was a transient spasm, but still we had to do a coronary angiography. There was no lesion. It was only like 5 minutes ST elevation. But and also our impression was probably in the CS, it seemed to be a little less efficient than radio frequency. And so for that application, we use PFA. So this is the cardio version, and now we're back to sinus rhythm. And so we will be able to check that set to be sure, is it blocked or not? That's the question. So let's start by pacing left atrial, left appendage, I mean, and you can see, I hope you can see, there is a distal to proximal CS conduction. So clearly the mitral is not blocked. Let's do an activation to try to understand better why is it not blocked. First pass. And so we won't do the map completely, just enough to really clearly understand the CS. And you can see that there is maybe a bit large here, but it seemed that the really initial part, it seems to go here, and maybe there is something that is missing. Maybe we've not been enough close to the annulus. And so let's have a look with the ablation. And you see, when you put your really ablation catheter there, you can see there is a very sharp and early signal there. And you see almost immediately when we did application, the CS shifted to proximal to distal application. And so it was just related to an endocardial gap at the annulus that was relatively easy to deal with. The rest of the line was blocked. The PV were isolated first pass. These signals are only related to the appendage far field. Pacing, exit, and entrance block was really demonstrated. And so this will be almost the final mapping of the map. So you can see that we are pacing from the CS here. And so very early is at the mid CS, and you can see that the roof seems to be blocked. At least it seems to be very purple. Here's the size. So usually we like to do overlap pacing. We really spread the octave on the wall, but in that case, the low voltage area was a bit too large to do it. But really, the result is relatively quite clear. And after, you will see the really final. CTI is a bit anecdotal, but still, it was efficiently done. And that the final map where you can see that pacing from the CS, you have a floor line that is clearly blocked. And so is the mitral with the mitral line. With in voltage, you see that all the rest of the atria, despite the fact that it's a 1 year AF 250 mil atria, is really remarkably well vaulted. And this is the final map doing that. Okay, and so I have just a few slides to sum up some of our results. Maybe you have some question at that point.
Yeah, I wanted to just kind of ask you before you got onto the slides about your workflow. You elegantly switched between PF and RF within anatomical locations, anterior and posterior, which made sense. But is there anything else? What stands out to me is there's some bench data on RF on scar is not maybe as effective as PF on scar or RF on previously ablated tissue versus PF on previously ablated tissue. So I saw that the areas where you had ethanol ablation, you use PF, but majority of it was posterior. But if it was anterior, would you still use RF, or would you switch out at that point?
That's a good question. Of course, most of the data is how PF is working into that low voltage and scar tissue is really used for, I think, for VT and all that complex tissue in the atria. Honestly, we have not had a lot of experience with that. I think for me, radio frequency, especially for the vein, is still the way to go for when it's safe related to the esophagus. But I think for the anterior part, if you want to reach a little bit more deep lesion, especially, I don't know, some people might be interested to do anterior lines in scarred area to reach the backman. That is maybe something that could be interesting, but honestly, I don't have the experience with that.
Brett, let me bring you in and ask you a question. You have been, you've lived in the world of point RF for many years, and you're one of the most efficient operators that we know. Where do you, and now we've kind of taken by the world of large footprint PFA catheters. Where do you see this focal catheter coming to play a role in our LEP lab again?
Well,
Yeah, that's a really big question.
Yeah, in my current workflow, I really like the way the large footprint catheters manage the posterior wall, even with esophageal deviation available and opening up the potential for posterior wall RF to be safer. It's very efficient to use the larger footprint catheters. But I do feel like in the thicker areas, particularly up on the superior portion of the ridge and septal portion of the ridge, I would prefer RF. And in the lateral mitral line as well, I still think the point-by-point catheter precision is very appealing. And the ability to analyze the local signals as you were doing during this case to understand what's happening at the previously ablated portions or lines allows a precision that's still quite appealing. With current generation PFA, I'm just not sure I trust it in the thickest regions, in particular, as I said, by the roof and by the posterior septal bundle and by the ridge. So I incorporate both in my current strategy.
I have to say that when I use a large footprint catheter today, I pray that I don't go into an SVT. because that's a struggle at that point with a large footprint. I want to ask Larry a question before we give it back to you, Nicolas. Larry, you have used a lot of software, especially things like ADAS, to look at pre-imaging to decide what kind of workflow you want. And Nicolas showed us a very elegant workflow, very extensive workflow for this disease atrium. Do you still do you feel like an atomic ablation like this versus imaging guided, imaging integrated, substrate modification, are they going to be adjunctive? Are they going to be one or the other? What are your thoughts when you see Nicolas's workflow?
Thank you, Debbie, and it's good to be here. I have to say that I have a fundamental disagreement with the case that was presented, and that involves how do we characterize our patients. So to determine that somebody is paroxysmal or persistent is a clinical diagnosis. It often does not give us any direct correlation to the anatomic substrate. So we really approach patients after we do our mapping, when we do voltage mapping, get a sense of what the substrate looks like, and try to adjust our ablation approach to that particular patient. I just think in this past case, this was a patient with pretty normal voltage all around, and the patient received very extensive ablation, which may be to their benefit, maybe not. But you could have had the exact same patient who was clinically paroxysmal with the same substrate, and you might have chosen just to do PVI. So, we're struggling with, what extent of ablation should we do based upon a clinical diagnosis? So we create a lot of lines, and we know, unfortunately, despite all the time that we've spent with both RF for sure and PFA now, that nothing is forever. These lines can break down. So whenever you create a line, you create the opportunity for an atrial tachycardia to come. And yes, we have technology to go after that. But my point is that it would be very nice if we understood the substrate a little bit better before we engaged in very aggressive ablation.
Nicolas, why don't you take back and show us some of your data?
Yeah, but I want to answer that, of course, because I completely, as you can imagine, I completely disagree with that point. You say that we're doing very extensive ablation, but I mean, in our work, we've demonstrated that the patient, when you do this line, they are placed at the collision, the normal collision of the atria. And so we've done a lot of echography after that, and we've shown that the left atria was also working very well. I think we've spent years to try to understand this substrate, and I think this leads to more aggressive lesion, because you create lesions that are sometimes suspended, which leads to ATAC. ATAC leads to more ablation, and so we're dealing with a 1-year persistent AF, 250 milliliters. So the atria is extremely enlarged. So, well, that's another debate. I can go to some of our experience that we've done using that strategy. And so the idea of the early experience we have was to try to understand if it was possible to have first pass block, especially of the mitral. Thus, PFA helps you to block the mitral without the need for doing ethanol infusion. And so in the PF group, and also in a control group of radiofrequency, in one part of the patient, we did initial ethanol infusion, as I showed you in the case. And in another part, we did delayed. It means that we did ethanol only if the mitral could not be blocked using a normal workflow. And so this is a bit of a summary of our results. And you can see that first pass PV isolation and dome block was really higher in the group of PF. It was only 30% with radiofrequency only, while in PF, especially for the dome, the rate of first block was much higher. And the final PV block was also relatively interesting. It's not 100%. Some of the flow were not blocked, but still it was really interesting, with the final set blocked in 90% of the case. For the mitral, I have to tell you really that we blocked only one patient in each group, only doing ablation without ethanol. So it seemed that also PF is not able to reach that level of block. So again, our strategy is really based on a complete set. I really don't agree with the fact when you say that it's extensive ablation. A less ablation, if you do it on the anterior wall, will have much more impact on the effectiveness of LF function. So it implies 2 lines more, roof and mitral, but it does not disrupt the way the left atria is activated, and it preserves. And I think there is not many papers that have produced data on LF function after ablation at 1 year. And we have shown that the left atria was really preserved using that strategy. So the dual energy ablation, in our experience, is safe, is feasible also under local anesthesia, and seems to be more effective, especially on the posterior wall. Thank you.
Would you consider
Thank you, Nicolas, for a
your
great presentation. Go ahead, Brett.
would you consider modifying your lesion set based on the substrate? I mean, when you see anterior scar and low voltage, or if you see fractionation and abnormal activation through the posterior wall, would you consider posterior wall isolation or an anterior mitral line, which in your case, after vein of Marshall, as the first step, would potentially result in left atrial appendage isolation?
So the question of the anterior wall low voltage has really, it's not only to have a size of the low voltage. If we do a full population of patients with persistent AF, there is, if you look at a very interesting data with fine mapping, you will see only less than 25 to 30% of the patient who has a 5 millimeter scar size according to this standard. So it represents really a small amount of the population. And so should we have a full lesion set that is only driven by this population? I'm not sure. The SUPRESS-AF trial was not working, and the other trial that tried to tackle that low voltage area was a bit of a deception. So for now, our first lesion set, we think it's more easy to deal with a complex anterior wall when the mitral line is blocked, rather than dealing with a perimitral using epicardial connection when you have done an anterior line that is not blocked and that you cannot block. Remember Silberbauer, he wants to do anterior line, he has to go epicardially in 2/3 of the patient to block that anterior line. The anterior line sometimes seems to be appealing, but it's difficult to check, because if you go epicardially, you will find 2/3 of still effective connection. And so I'm not sure. There is trial, and we are part of this trial. So I don't have a definitive question. There is trial ongoing. We will see if the anterior, posterior in the setting of low voltage is what is the best. But remember, it's only 20 to 25% of the patient. There is any other question?
Just to reiterate my point.
Myocardial depression from, sorry, Larry, go ahead.
No, you go ahead. It's okay.
About 5%, maybe a little more patients when you initially inject alcohol have some desaturation and some myocardial depression. Have you had to manage that? It's definitely a concern in particular patients who present with already a low ejection fraction. It can be almost protamine-like in the challenges that it creates when you initially inject the alcohol. Do you feel like it's maybe related to the vein and the extent of the venous network that you inject when you inject the alcohol, or how do you manage that?
So you said there is 5%. What is the stat that you just mentioned, and where is
So
it
we
coming?
noticed We noticed about 5% of our patients, when we inject the alcohol, have some evidence of acute either myocardial depression. We see the end tidal CO2 significantly drop or desaturation. It's brief, it's almost protamine-like in its duration, but in patients who have minimal or low myocardial reserve, it can be challenging to deal with those. So it's not frequent, but it can be a bit unpredictable and challenging with the alcohol.
Okay. For me, it's difficult to answer that. We've published more than 700 cases, and we have not noticed that. And there is a multiform European, and it's a very large survey that have been published by the group of Bruges about ethanol, and they don't talk about that level of depression. That something that we have reported into that series was a very over 700 cases. It was a handful of cases, like 2 or 3 cases of acute anaphylactic non-specific response. It was related to fast injection. This is why we do 3 times 3 cc on over 1 minute each injection. If you do fast injection, there is sometimes cases of anaphylactic non-specific response that can be of concern. But honestly, we've done that in very severe patient that was with very depressed LV function, and it's not. No, I don't have that experience at all.
Well, unfortunately, we're out of time. Thank you, Nicolas, for a great case, and to your team in University Hospital in Bordeaux. Thanks to our faculty, Larry and Brett. For the next session, I will hand over to RIO co-director Jason Andrade, coming right up.